Hey everyone, welcome back to Izzy Medicine, where we take all the squiggly lines of medicine and try to make sense of them. Today, fittingly enough, we're going to try to learn how to read an EKG. And we're going to start with the heart's electrical system. We're going to talk about the SA node, the AV node, the bundle branches, Purkinje fibers, the whole shebang. And then we're going to learn step by step how to read an EKG. And because there's just so much fun to be had and so much EKG to be learned, this is going to be part one of a very, very, very entertaining 3-part series. So grab a pen, grab a pillow, grab a snack, grab a caffeinated drink, and let's begin. So let's get into it. What's the heart actually doing? So the heart isn't a nerve network when it conducts electricity. It's actually made out of specialized cardiac muscle cells called myocytes, and they can generate and conduct electrical signals all on their own, usually through sodium-potassium pumps, and calcium is involved. So where does this pathway start? The SA node is the pacemaker of the heart. That's where it starts. It sits in the right atrium, and this is where the electrical impulse begins, kind of like lighting the fuse. Once it fires, the signal spreads through both atria and it triggers them to contract and push blood into the ventricles. This contraction, the wave of atrial depolarization, is what gives us our beautiful, regular, mushroom-shaped P wave on the EKG waveform. After that, the signal travels to the AV node, and the AV node sits at the junction between the atria and the ventricles, and it kind of acts like a bouncer at a club, where it slows the signal down just enough to let the atria finish squeezing before the ventricles take over. This pause with the atrial contraction and the pause in the AV node is our PR interval. From the AV node, the signal shoots down the bundle of His. It's a narrow highway through the interventricular septum. Conduction through the bundle of His is still part of the PR interval, but now we're just transitioning right into ventricular conduction. The bundle of His splits into the right and left bundle branches, which run down the interventricular septum and coincidentally go to the right ventricle and the left ventricle. From there, the signal spreads into the Purkinje fibers, which fan out across the ventricular walls, and they deliver the impulse to the ventricular muscle cells to contract. This rapid depolarization and contraction of the ventricles, that produces our beautiful, perfect QRS complex. In between there, we have our isoelectric ST segment, where there's no electrical conductivity, and this is kind of the pause of ventricular relaxation right before the T wave, before we have ventricular repolarization again. Okay, now that we understand this beautiful system, let's look at the EKG paper, because sometimes looking at an EKG paper feels like a foreign language, and if we don't understand it, the rest doesn't make sense. Some of you probably already know, but let's review. Basically, the EKG strip is a graph. There's time on the horizontal axis and voltage on the vertical axis. Each small horizontal box is 0.4 seconds. Each big box of small boxes is 0.2 seconds. Vertically, each box is 0.1 millivolts. So when we measure intervals like PR, QRS, QT, we're actually counting how many small boxes something takes up horizontally, and that gives it to us in seconds. And this is where we determine if we have a bundle branch block, if we have QT prolongation, if we have an AV node block, and how long something is supposed to take as opposed to how long it's actually taking. The same thing with amplitude. When we look at our ST segment specifically, when a patient has chest pain, it's supposed to be isoelectric. There's not supposed to be any elevation. If all of a sudden we see a 0.1 millivolt or 0.2 millivolt elevation, or actually a depression, that can indicate a lot of things like ischemia or actually an infarction. So this is where this little graph helps us figure out what's going on with our patient. Next, before we get into our super duper fun rhythms, we have to know how to calculate our heart rate, because the rhythms really are rate dependent a lot of the times. So let's start with my favorite method, which is the Start 300 method, which is one that I learned as a student, as a baby youngin', and I still use on a daily basis when I look at EKGs. The Start 300 method essentially is utilized for a regular rhythm. So how do we know that it's regular? Is when our R to R intervals are equal. If we have an R and In 3 boxes, we have another one. And in 3 boxes, we have another one. And in 3 boxes, we have another one. It's regular, and we can utilize the start 300 method. So what we do is we start by finding an R wave that lands on a bold line, and that's start. From there, we count each big box that follows, and we count start 300, 150, 100, 75, 60, 50. We do that until we land on the next R wave, and wherever the next R wave lands, that's our heart rate. So for example, here, start 300, 150, 100, 75, heart rate of 75. This can be utilized when the heart rate is regular. What do we do when the heart rate is irregular? And how do we know that it's irregular? We know that it's irregular because we have an R wave, and then 3 boxes later, we have another one, and then 7 boxes later, we have another one, and then 2 boxes later, we have another one. And that's mayhem, and we know that it's not beating regularly, so we can't use our start 300 method. What we use here is we use the strip method. So either we have a 6-second strip, so we count all the R waves in the 6-second strip, and we multiply that by 10. If we have a 10-second strip, we count all the R waves and multiply by 6. So for example, this is a 6-second strip. 1, 2, 3, 4, 5, 6, 7, 8, 9. Multiply by 10, 90. So we can get a decent estimate of the heart rate. It's not exact, but it's good enough when the pacing is wonky and unpredictable. All right, now that we know this, all these fun things, graphs, heart rates, let's get into actually learning rhythms. Let's start with normal sinus rhythm. This is the beautiful gold standard. Here, the SA note is pacing the heart. Everything is in order. We have a little mushroomy cap, beautiful P wave before every beautiful, perfectly spaced 2 to 3 boxes QRS. The PR interval is in that sweet spot, 0.12 to 0.2 second window, and the rhythm is steady. Those R to R intervals march out like soldiers. And what's the rate here with normal sinus? Between 60 to 100 beats per minute. Everything looks beautiful. Nothing's dragging. Nothing's skipping. This is what a normal, healthy heartbeat looks like on paper. And then we get to sinus bradycardia. This is normal sinus rhythm, just slower. So we still have 1 P wave before each QRS. We still have regular spacing between the R to R intervals. Only the heart rate is under 60 beats per minute. Sometimes bradycardia is totally fine. So for example, if we have an endurance athlete or a marathon runner, their heart pumps more efficiently, their ventricles contract forcefully and send blood just so efficiently and beautifully that they don't need a fast heart rate, so their heart rate is slow. If we have a person that's sleeping very, very deeply, they don't need anything but sleeping, so their heart slows down and contracts efficiently and slowly. But if we have a patient that's tired, think about hypothyroidism. If we have a patient that's hypotensive, we have to think about systemic reasons for this bradycardia, or maybe they're on a beta blocker or a calcium channel blocker, and that's what's slowing down their heart rate. If they're lightheaded, maybe this rhythm is not maintaining perfusion and we need to figure out why. The key here is not just to figure out why it's slow, but also remembering that the rhythm is still normal in structure, it's just slower than expected. On the flip side, we have sinus tachycardia. Here, the SA node is working overtime. It's sending signals much faster. The heart rate is about 100 beats per minute or more, but the sequence is still normal. We still have a P wave, a PR interval, a beautiful QRS, a T wave, and then rinse and repeat. It's fast, but still organized. With sinus tachycardia, there's always a reason. The heart is not going rogue here. It's just the body asking for faster output. And this is where we ask ourselves, why? We have to think, is our patient in pain? Do they have fever? Are they anxious? Are they dehydrated and the body is just trying to pump that low volume a little bit quicker to oxygenate? Are they hypoxic? Do they have a really bad pneumonia? Do they have a pulmonary embolism and we're trying to supply oxygenation? Do they have a metabolic issue? Do they have hyperthyroidism and their metabolic rate is through the roof and the heart is pumping? So the job with sinus tachycardia isn't just to slow the rhythm, it's to figure out what the heart is responding to and correct it, and then we correct our sinus tachycardia. Alrighty, we get to arrhythmias. Let's jump from sinus tachycardia into tachyarrhythmias. With tachyarrhythmias, the smartest thing to do is divide them. We have to think about, are they narrow or wide? And are they regular or irregular? Let's tackle the narrow and regular first because those are really cool and I really like them. So, narrow complex regular rhythms. These are fast rhythms and the signal is still going through the regular ventricular conduction system, hence the narrow QRS, and they're firing consistently, normal R to R intervals. A really cool one is supraventricular tachycardia. It's a very fast rhythm, very, very fast, usually 150 to 250 beats per minute. And what happens here, because it's so fast, we'll often see no clear P waves. They're sometimes buried under the T waves or they're lost altogether. But what differentiates SVT from AFib is that the R to R intervals are textbook regular, like drawn with a ruler. So if it's 150 beats per minute, it's 150 beats per minute on the dot. What's happening is a little re-entry circuit, either in the atria or through the AV node, and the signal just keeps cycling. The SA node isn't in charge here anymore. It's supraventricular, so it's above the ventricle, but not in the SA node. Patients often say it hits them suddenly, like heart pressed on a gas pedal or heart jumped into their throat. And when we see an SVT, we have to break the loop. There's a couple of ways to break the loop. We can do a vagal maneuver. So one vagal maneuver I've had to do in the office is gag a patient with a tongue depressor. That's a vagal maneuver. I've also had to dunk a patient's face into ice water in my lifetime. And that's a vagal maneuver. I've had to call the cardiologist from upstairs to do a carotid massage. That's a vagal maneuver that has to be done carefully and only on one side. And I've also asked patients to strain. That's a vagal maneuver. And if that fails and you happen to be in the emergency room and not in a primary care setting, you can administer adenosine. And that should break the SVT. Next is another really fun one that I really like because I like how it looks, is narrow tachycardia with atrial flutter. Atrial flutter is only regular though when the AV node is conducting in a fixed pattern, like a 2-to-1 pattern. What happens in atrial flutter is that it comes from a macro reentry loop in the right atrium and it spins at around 300 beats per minute. But when it arrives at the AV node filters that down to a ventricular rate of about 100 to 150. And what you get is this beautiful sawtooth pattern in leads 2, 3, and AVF. So if it's a regular block pattern, you have maybe 2 sawtooth patterns to 1 QRS or 3 sawtooth patterns to 1 QRS, and the sawtooth pattern looks really nice, really sawtooth-like, and a narrow QRS that's regular. Now we move on to the narrow and irregular rhythms. These are so fun. They're a complete disaster of a mess. They have absolutely no pattern. R to R intervals all over the place. When we see that, we think about 3 things: either atrial fibrillation, variable misbehaving flutter, or one of my favorites, very rare but very fun, multifocal atrial tachycardia. Let's start with atrial fibrillation because this one's actually a big one, very common. We see it in primary care, we see it in emergency, and we need to know how to recognize it. With atrial fibrillation, there are no P waves. They're just these fine, chaotic squiggles along the baseline. Why is this happening? It's happening because literally the atria are quivering. They're fibrillating. They're not contracting. And what happens is the AV node is picking up these signals at random and it sends narrow QRS complexes that come and go when they feel like it. Absolutely no rhyme or reason. And then we have this quivering, completely unformed lack of P waves where the atria is just sitting and shaking. And this is why this rhythm is called irregularly irregular, because there's random QRSs with random squiggles. Because atrial fibrillation means that the atria have lost their ability to pump effectively and contract, we have a risk for clots. Why? So when we have an atria that contracts beautifully and normally from the SA node, it contracts fully, it sends blood to the ventricles, the whole system continues, we oxygenate our body. When this doesn't happen and the atria is sitting and quivering, there's stagnant blood. What happens when there's stagnant blood? You've seen it in a test tube when you draw blood. You've seen it on a wound when blood sits and stagnates. It clots. So this is why with atrial fibrillation, we don't just worry about the rhythm, we worry about stroke risk, because at any point with a quivering atria, one of these clots can shoot up, go to the brain, cause a blockage. And that's why our patients with atrial fibrillation are on anticoagulation therapy such as Coumadin. As I alluded, our atrial flutter doesn't always behave nicely. Instead of a beautiful 2-to-1 ratio with beautiful saws, sometimes you get variable conduction where the AV node just lets through some beats and skips others, and then you get all this weird looking small flutters looking irregular with an occasional QRS. And now, my favorite, multifocal atrial tachycardia. So what's the hallmark of multifocal atrial tachycardia? It's when we have 3 or more different looking P waves and an irregular rhythm. Why do we have this? As the name suggests, instead of having one nice SA node conduction, we have multiple foci in the atria that think that they're pacemakers. So one time we can have one foci shooting and the P wave can look flat and wide. Another time, another foci is like, I'm the pacemaker, and it's kind of raised and triangular. And another time we can have one that's all bumpy and lumpy. And in all of these foci shooting, we'll have a random QRS that's caught through the AV node and gets sent out here and there. So we have an irregular, narrow QRS, but unlike atrial fibrillation, they're still P waves. They're just little weird looking deformed P waves and chaotic in its origin. But I really like multifocal atrial tachycardia. It's not fun for the patient, but it's really cute on EKG waveform. All right, guys, with this sheer excitement about MAT is where we're going to pause for now. We just walked through the most common and most chaotic of the narrow complex rhythms, from sinus tachycardia doing its job to atrial fibrillation doing whatever the hell it wants, and even MAT throwing its own chaotic party. In part 2, we're going to head into more dangerous territory. We're going to cover wide complex tachyarrhythmias like VTAC and Torsades. We're going to follow it by bradyarrhythmias and AV blocks. So take a breath, grab a snack, grab some coffee, and I'll meet you in the next one where we learn what to do when the ventricles take over. I hope you enjoyed part 1. If you did, don't forget to like, subscribe, leave a comment so I can answer any questions. And as always, thank you for being here. Stay curious, stay kind, and I'll see you in the next one. Bye.